Thank you.
Webcast. Alright, so we're ready to go. Check okay. I think we understand everything ready.
Good afternoon, everybody, and welcome. This is our annual Sellars lecture. My name is Robert Emberley, and I'll be your host this afternoon. You know, we're kind of like family here. Look around all the pages. Many people I've met, some we haven't met. Some feel like you're the cousin that you kind of step away from for a little while. Just like that. The annual medal. Let me slow down. Take a deep breath. Okay, that's better. The annual Sellars lecture was made possible by a request made by Mrs. Sellars upon her passing to honor her late sister Helen, who lived with Parkinson's disease. Mrs. Sellars didn't give any instructions as how the money was to be spent. But the Board of Parkinson's Society felt that it would be fitting to ensure that Mrs. Sellars' gift would have a long-lasting legacy. And in the wisdom, we have this lecture series. Our plan with these lectures is to bring in Parkinson's experts to talk directly to our members who are living with Parkinson's, their caregivers, and our medical professionals. Like I said, we're sort of like family. We are all in this together. Who said that? Somebody on television. We need to ensure that we have constant communication about our successes, our struggles, and the possibilities of beating this disease. Again, we're all in this together. Keep your stick on the ice. Look around this cool room of fellow Parkinson's people. I'm pretty sure Mrs. Sellars would be happy with what we have here. This year we are webcasting around the world. Where's the camera? Hello, everybody out there. I guess I better introduce myself. I'm Robert. I'm just one of the crowd here. I was diagnosed with Parkinson's, classical Parkinson's, 5.5 years ago. I found out lately that I no longer have just normal Parkinson's, I have atypical Parkinson's. My wife diagnosed that. Robert, she said, there's nothing typical about you. And with Parkinson's, there's no exception. You know, the teachers at school thought I was special too. I was so special. This is actual fact. My grade 3 teacher thought I was so special. She asked me to spend the second year in grade 3. Yes, our local chapter of Parkinson's Association, we're a little bit different. In our group, I'm one of the typical atypical. Let's get serious. One time, if you were diagnosed with Parkinson's disease, your life was over. Now, there blows a wind of hope, a new breeze of anticipation, a new attitude. Hope is beginning to really abound. In our local chapter, we have gym classes, we have choir, and ballet is coming. I'm looking forward to that one. Seriously, I am. And we have fun. We have parties, we dress up, we dance, we dance the jig, and we use the ugly stick. Now, I've been talking about our society on Facebook to people in Britain, Spain, USA, and Australia. You dance the what? The jig. And you use a what? Ugly stick. What's an ugly stick? I tell them to Google it. And they Google it, they say, we want to do this. We're trying something new here now. And we've gathered to learn about it. Deep brain stimulation. I told a good doctor that I've done a little brain surgery myself. A few years ago, my neighbor asked me to get him ready for a Halloween party. I did. There's a picture there.
Here, one moment there. It's not, we aren't able to bring it up on the projector. But,
Okay.
But
I can show it for you.
yeah, no worries.
We'll give them a read it up.
We'll put it up at the end there. Yeah.
I dressed him up. And the first thing you see the stitches and everything, and the second picture you can see that he has his brain in the bottle. I thought I did a nice job on the stitches. And he's holding his brain in a jar in his lap. I thought it was a mindless operation. When I took these pictures, did this 15 years ago, the actual real thing was so far removed from me that it was funny. It was inconceivable to think that at some time in my history or my future, I might be subject to brain surgery. Now we see it as a beautiful, real hope. Something that's there special for us. I'm going to ask our guests to come and share this hope with our audience here and around the world. I'm going to find my page here. And now to our future attraction. Here it goes. I did.
I'm not doing any acrobat.
Blame Dirk for that one. Dr. Kyna Squarey is known to many of you in this room. She is a neurologist with Eastern Health and works with both the neurology clinic at the Health Science Center as well as the movement disorder clinic at the Miller Center. Dr. Squarey is also an assistant professor of medicine at Memorial University Faculty of Medicine. Dr. Squarey, the podium is yours.
I'm not actually going to use the podium. I'm just kind of going to stand here, but I'm not going to do any acrobatics this afternoon. For anybody that doesn't know me, my name is Kyna. I'm a neurologist at the Health Sciences Center. And we're going to start actually with a video. And this is a video of Andy Berry. For anybody that doesn't know who he is, he was a Toronto-based radio personality for CBC. So if you go off, thank you. Yeah, you should be able to hear it though. There's no sound.
I was in my car one day, because I was driving along, I started to huge walk. I was walking towards the coffee shop. I sort of noticed I was crowding across the floor into the line, beyond my power. And then I began noticing the writing and handwriting was getting increasingly small. And then I was in my car one day, as I was driving along, I felt a huge log just sort of fall in my hands. Where did that come from? So I went home that day and I put in the Google, altered date, crabbed handwriting, and drooling. It came up, Parkinson's. I started taking 2 pills a day, not 20 pills a day. And what you're seeing right now is like this confusion. It is a reaction to the drug, it's not Parkinson's. This is treatment in some ways in the clinic. The only important thing I could do to make that better is to get the deep brain stimulation.
Right there.
It took 6 hours. And probably locate using MRI, probably locate a space in the brain called the subthalamic nucleus, which is responsible for Parkinson's.
Having fluctuations every hour to an hour and a half in medication, going from not enough to too much to not enough. That's what we want to help with.
When they turn on the stimulator, we don't know exactly what it is without the drugs to it. And then they move on. Pretty strange sensations. Very hard to describe. And it was interesting.
Is it normal for you now?
Even that first day.
So we're going to talk a little bit about deep brain stimulation. I wanted to thank you all for coming today, as well as the people who are watching from home. Thank Medtronic for helping us sponsor this today. And we'll go on now. So what is deep brain stimulation?
DBS therapy uses a medical device, much like a cardiac pacemaker, and thin, soft, flexible wires called leads completely inside the body. While the device is implanted beneath the skin of the chest, the leads are implanted within the brain. Electrical stimulation is then sent directly to targeted areas within the brain. Stimulation of these areas enables the brain circuits that control movement to function better. This results in a reduction of some symptoms in many patients.
So what is DBS therapy? So it's deep brain stimulation. It's just as the name says. It's implanting an electrode into the brain to deliver electrical stimulation to certain structures in the brain that are responsible for the control of movement. And those structures include things like the subthalamic nucleus, the globus pallidus interna, and the ventral intermediate nucleus of the thalamus. How does DBS work? You know, I don't think we know exactly how it works, but it does, and it does so by modulating or changing the abnormal circuits that are responsible for the movement disorder symptoms that we see in Parkinson's disease, and thus bringing them under control. So there are 3 main components involved in deep brain stimulation. The first is the implantable pulse generator, or the neurostimulator, and that's this device. And it's implanted, basically, it's like a pacemaker, and it's just planted under your clavicle here in your chest. And I'll just pass that around so you guys can have a little look at it. And then it's connected via an extension to leads that are implanted in the brain that deliver the stimulation. So each lead has 4 electrodes, and what that does is it offers us a way to combine, to have a variety of combinations to stimulate the brain and adjust the location and shape of the stimulation field. The battery, or the implantable neurostimulator, generates and delivers the stimulation. And there are three main kinds, the Activa SC, PC, and RC, the RC being a rechargeable battery. And then you can come to see your local neurologist and they can program your DBS, and we do that wirelessly. We also give you a patient programmer, and you can check periodically the status of the battery, if it's working well, because it is a battery and only lasts about 4 years, so you do have to have it changed periodically. And you can also adjust the stimulation parameters if you're comfortable doing so. The components of successful deep brain stimulation therapy, first of all, most importantly, is choosing the appropriate patient. So not everybody is a candidate for deep brain stimulation. I will talk a little bit more about that a little later on. The second most important is having the appropriate placement of the lead. So the lead has to be implanted in the proper place in the brain for it to work. And then optimal post-operative management care. And that involves, optimal programming of the stimulator, adjusting your medications, managing side effects, as well as providing the patient with support and education about their stimulator. So who is a candidate for DBS? So as I said, not everybody is. The inclusion criteria would I'll actually go back. Sorry. So there are different types of targets for deep brain stimulation. The most commonly targeted area in the brain for Parkinson's disease is what Eddie Fair described as the subthalamic nucleus. So that's located right here. Another target commonly used would be the lobus pallidus interna, and that is a target that's often used as well in the treatment of another neurological condition called dystonia. The thalamus is a structure that can be stimulated for patients that have problems with tremors. You might have heard of conditions such as benign tremor, or for a patient with Parkinson's disease, really the main problem is tremor, and that might be another target. So what should you expect from this therapy? It results in improvement in the non-axial signs. So that means signs in the limbs. So things like tremor, stiffness, and slowness of movement in your arms and legs. It doesn't help as much in the axial signs. The axial signs being gait, balance, falling. Patients experience less motor fluctuations. And what I mean by that is over time, people become more reliant on their medications. And they have to take their medications on time. If they don't, sometimes they experience a recurrence of their Parkinsonian symptoms, and that's called wearing off. So DBS helps to control that. It also results in a potential reduction in levodopa dosage, and thereby people don't have as much dyskinesias. If you don't know what dyskinesias are, they're those wiggly, squiggly type movements that you ever seen in like what you find sometimes on television. So those are actually a side effect of levodopa treatment. And a lot of times after your DBS therapy, we don't expect to get you off of all of your medications, but there can be a reduction in doses, and therefore there will be a change in the drug regimen. It does have some effect on non-motor symptoms such as sleep. People often report that they have an improvement in their sleep. Negative side effects of deep brain stimulation are that I have often seen patients have trouble with their speech after. And it doesn't have an effect on cognitive function, but if people have problems before the surgery, then they tend to have more problems with their cognitive function after surgery. So, who is a good candidate for DBS? It's a patient who has levodopa responsive Parkinson's disease. So, what symptoms are improved from the treatment with levodopa are the symptoms that are going to be improved with deep brain stimulation. Patients that we often say that patients should have the disease for about 4 years, and the reason is that we don't want to operate on people that have an atypical Parkinsonian syndrome.
The surgery is best for people that are younger, so less than 65 years in age in general. Is it okay? They're for people that experience motor fluctuations, despite optimal medical management, as well as those that are experiencing dyskinesias. They have a good response to levodopa challenge. Denise is going to talk a little bit about the levodopa challenge. Usually what we do is patients don't take their medications overnight. They come in, they get a dose of levodopa, and then they measure based on the Unified Parkinson's Disease Rating Scale, the improvement in their symptoms. And if there's an improvement by about 30 to 40%, then the patient is considered a candidate for DBS therapy. So the ideal candidate is someone who's severely disabled in the off condition and independent in the on condition. People that are not considered good candidates for DBS therapy are patients who have unstable depression with suicide risk, people that have psychiatric manifestations of the disease such as psychosis, people that do have cognitive decline or dementia, and patients that have impulse control disorders. So you've probably seen that in the, on TV. It's commonly associated with the dopamine agonist, so problems with things like compulsive shopping, gambling, hypersexuality, punding being doing things over and over and over again, like labeling. People that have unstable medical conditions, so people that have significant heart disease, infections, cancer, because it is a surgery after all. And anybody that has marked abnormalities in their imaging, so if you have a lot of small vessel disease, like mini strokes in your brain, in large ventricles, atrophy, or any kind of big lesion in your brain, you wouldn't be considered a candidate. So after you have your surgery, what happens to you? Denise is going to delve into this a little bit more, but typically the stimulator is not turned on right away. There's a healing period. Typically, say at the Toronto Western, they wait 4 or 5 weeks before they turn on your neurostimulator. Usually, it's a morning visit. You come in, you don't take your medications overnight, and then they turn your stimulator on, and they program it. So they test each of those 4 leads, or 4 electrodes of your lead to see what is the best lead for you without causing you any side effects. And how we assess what's the best setting for you is based on your symptoms. Is it controlling your stiffness, tremor, slowness of movement without causing you adverse effects? So it's important that you recognize that in patients with Parkinson's disease, our goal is not to get rid of all your medications. On average, patients do typically decrease the amount of medications by, on the average, 40 to 50%, but it has to be done very slowly, as if we try and take away the medications too quickly, people experience negative side effects like apathy, depression, akinesia, so slowness of movement, freezing of gait, and restless legs. So I just have a couple. I'm not going to bore you too much with a lot of research studies, but I think it's important for you to see that there is science behind this. This was a study done by Elena Morrow, and she used to be a neurologist at the Toronto Western, and she showed that over time, the maximal therapeutic benefit of DBS over time. So if you look at the y-axis, this is looking at the UPDRS motor score. So a negative or a smaller value is better. You have less Parkinsonian symptoms. So what you saw is after the first year, first month, there's a reduction in that score by about 30%, and then by the first year, there's a further reduction by about 40%. DBS therapy improves motor scores by about 54% overall. And this is for all of the symptoms of principal motor syndrome, including the stiffness and the slowness of movement.
As I just mentioned to you, this therapy allows for the reduction of your tolerated overdose on the order in this study by Crack in 2003 by about 63%. Patients with Parkinson's are noted to perform their activities of daily living better. And also, it not only helps the patient with Parkinson's disease, but it also helps improve the quality of life for their caregiver. So follow-up therapies are important. You don't come and see me once and then go, or whoever your neurologist is, and go away. You have to come back for routine follow-up visits. At each visit, your symptoms are assessed, your stimulator is assessed, and the medications are assessed and adjusted. The device is interrogated, and that means we check the battery life. We also check that the impedances are not too high or too low. So I think it's important that education, we talked a little bit about education. We need to manage expectations. This is not a cure. It's kind of, if you think about the armamentarium of Parkinson's disease, you know, as you go through the disease, your medications get adjusted, right? You tend to get more and more medications. This therapy tends to reset the disease. Certainly we can back off on the medications, and then, but it isn't a cure. It's kind of like the next step of medical management, and maximum medical management is not enough. The optimal results will vary from patient to patient. And over time, as I mentioned, you'll have to have the stimulator adjusted as well as your medications. You'll be taught how to monitor and adjust your stimulator. We have to prevent complications. So just the other day, we had a gentleman who had been falling, and he had a big bruise over his stimulator and had to be replaced. It can get infected, or it can break. It is a medical device, right? So we have to prevent those complications. That doesn't, just because you do DBS therapy doesn't mean you don't continue to exercise and do all those important things. To continue to participate with the allied health care, so physical therapy, occupational therapy, your speech therapist. And it's also important to realize that this therapy it kind of does reset the disease. So people have been progressing throughout their disease course, and all of a sudden they're more normal. So that's a big adjustment sometimes, not only for the person, but also for the caregiver. So support groups are important. Not everybody has a benefit from DBS therapy. Why might that be? Well, poor lead placement is probably the most common. The programming parameters may not be appropriate, or the medications that you're taking may not be right. As I said, this is a device, and there could be problems with it. Maybe you have one of the atypical Parkinsonian syndromes and not. It does have a battery, and that battery has to be replaced. You can, at present, magnetic fields can interfere with the nerve stimulator. You can have an MRI of the brain, but coming down the pipeline, you might be able to have an MRI of other parts of your body, but right now that's not the case. And there can be short circuits in the electrodes, which will then need to be replaced. So I'm going to finish here with just a video of a patient that has undergone DBS therapy, and then I'm going to turn it over to Denise. So Mike is a patient who was diagnosed with Parkinson's at age 47. He has stiffness, shaking, and dyskinesias. It all started with his deficit in his system. If he didn't have good time, he couldn't do anything. Even then, it got to the point where you might get in a restaurant, but you couldn't get out. So, because his medicine wasn't working and he couldn't walk. So sometimes you just didn't go because it's easier to stay home than to go.
I was taking the pill every 2 hours. And sometimes the pill would work, and sometimes it wouldn't. And when it worked, I had about an hour of good time, which meant the half hour that I waited for it to work, and a half hour before the next pill was down. So I really only had 1 hour of good out of the 3.
He did help at times. He got to the point where he didn't eat unless his medicine was working. So was working with me. We didn't get very much. Like I say, when I was supposed to, wasn't doing that, we didn't do as often anymore because of not being sure how much time to do something like that.
It's been a complete turnaround. Everything's so much nicer to done and to do it. It's unbelievable. Every day I wake up, I don't believe it. Because everything is just so much nicer. I'm able to go out here, I was able to go before. That was a big thing for me because I bowled for years and I bowled Wesley and it was hard to get that out.
It turned really well, really well. It's just finding new ways to make it all better.
Okay, so I'm going to stop there and turn over to Denise Murphy, who many of you, if not all of you, know. She's a nurse who was someone who went to Shears clinic, and she has certainly over 25 years' experience on there this morning. So she's going to give you some good information, I'm sure.
Thank you, Dr. Squarey. Are you on the web? It's kind of strange to Kyna please refresh
Big blue screen there, right there.
I'm not an electronic person. Our next family member, I say family member because we are a pretty close bunch, is Denise. And we were just thinking all her credentials. But for us, she's just Denise. And she's one of, I'll give it to you again. And I'm not good at this. She's been a friend of the Parkinson Society for 25 years now. Denise is a nurse coordinator of the Movement Disorder Clinic of Eastern Europe. Denise is also a recipient of the prestigious Parkinson Society of Newfoundland and Labrador Annual Award, which recognizes her outstanding support of the Parkinson's community in Newfoundland and Labrador. And she really does support us. We all know her. She's just Denise. Denise, come on.
So I'm just going to talk a little bit about So can you hear me now? Okay. So as you know, the surgery is not available here in Newfoundland, Labrador. So, the surgery itself is, it's a big decision for people to make to go ahead and have this done. But it's even totally hard for people here because they have to travel away, they have to be away from their family, and they have to be away for a number of months. So, just talk about a little bit about some of the things that have to be done, some procedures to make sure that people are good candidates for the surgery. And Dr. Squarey talked about making sure that someone is a good candidate. Because as we know, Parkinson is very unique for everybody. Nobody is the same. Different symptoms, some people have tremors, some people don't have tremors. So, Dr. Squarey talked about, all the specific criteria for a patient that would benefit from brain stimulation. So, in order to find out if people meet all these criteria, such as having particular features, the good response to the stimulant, so we know the patients, we do everything we can to tweak the medication before patients decide to have surgery. Absence of cognitive problems, depression, appropriate age, just certain things that we do to make sure that people meet these criteria. So the first thing that we do is, and everyone's a neurologist, had said that, evaluate the patient, they think they're a good candidate, the patient tells us that they would like to go ahead with the surgery. Patients are referred mainly to the Toronto Western Hospital. Some patients, especially up on the West Coast, were referred to Halifax, but the neurosurgeon there has left. So most of our patients do travel to Toronto. So before they go, we do try to do certain things, certain procedures to make sure that they do meet all the criteria. An MRI is performed and to make sure that there isn't any other underlying factors, such as severe vascular disease or lesion in the brain that the patient under. Neuropsychological evaluation is very important. So if the patient had a lot of memory problems, they wouldn't be a good candidate because it possibly could TBS surgery could, and patients had significant problems, it could make their memory worse. So we want to make sure that that's okay. If someone was having a lot of problems with depression, we know depression is very common in Parkinson's. So if the depression is controlled and they're doing well with it, then usually they can go ahead and have the surgery. But most times they would like the patients to be referred to a psychiatrist and be evaluated and make sure that they are doing fine, because depression can be made worse by decreased surgery. And right now, over the last year, we've been noticing that patients have been getting called after Toronto receives their referral. They've been asked to go to St. Clair's and do a video conference with the team. There's some members of the team from Toronto, which is really helpful because, patients will often have lots of questions, and also the team can, find out some information about the patient before they travel. So it usually takes probably, time varies to get to Toronto. It could be anywhere from 6 months to 8 months after we send a referral before they get the call to go on. So when patients go for that first visit, and it's never, patients don't go up for that first visit and have surgery. They always have to go up for 2 visits. So they go. One of the first things that what we've done is the challenge, and patients would be asked not to take their medications probably after midnight. And then they're going to come into the clinic at 12 o'clock, early in the morning. So they don't take it after midnight, come in 7 or 8 o'clock in the morning. And that's something that patients find so difficult, because these patients that are going for the surgery, they need their medications. They're taking them every 2 to 3 hours quite often. So that means that, and they're not staying in the hospital, so they're in an outside accommodation. They have to get to the clinic without medications, so that can be very difficult. And so patients are big takes. The same testing that Dr. Squarey would do in the patients in clinic, looking at hand movements, looking at the gait, so seeing how people are doing when they're in the off state. And then they're given the medication. And once the medication is cut in, and they want to make sure that there is a good response from the center. If there's no response, then often patients are not eligible for the surgery. And so they may have to have another MRI, either at that visit or certainly when they go up for the surgery. And other testing like EKGs, blood work would have to be performed. And this is 18 people, so it's a very intense evaluation. Very tiring for patients, especially when you're living in a hotel while you're up there, and it can be a very stressful time. So, in regards to cost, so the device itself, the Newfoundland Labrador government does pay for the device. It's about so we get an invoice after the patient is seen, and if they're felt to be a good candidate, Toronto will send us an invoice for $18,000, and that's sent off to the government, and they usually very quickly will fax us back and give us for that patient to have the surgery paid for. So when the patients come back, it may be several months or even up to 6 or 7 months before they get that call to have surgery. So the waiting list is quite long, and so the travel costs. Airfare, sometimes we'll use co-fare for some of our patients if they have difficulty paying for the airfare. And hotels, meals, you know, it has been changing with how much the government will pay, but it seems to be somewhere around half of, they get about $3,000, up to $3,000 a month. It probably they pay half of it when people submit the bill. So everybody has to pay up front, and then they have to submit the cost. And I think after they go over the 3,000, they pay from 75% of the remaining 3,000. So it was 7,000 per month that the cost for living out there. Then they would pay 75% of the 4,000. So it is a costly for sure. And so patients often are required, first when patients went out for surgery, they were not allowed to be back within a couple of weeks, but now it's taking longer and longer to get the programming complete. They really want to make sure that programming is working properly, so it's many visits back and forth from wherever you're staying in Toronto to the clinic. So it's not an easy trip to make. And so when preparing for surgery, we ask patients to really educate themselves. To really know, ask the right questions. Find out exactly what the surgery is going to do for you. Because it's not a cure, but it certainly can make a big difference in quality of life. So, if you need a literature on it, you can certainly call us and we can provide patients with the appropriate literature. And make a list of questions to talk to your neurologist or to the team in contact. And often we try to hook people up with someone that's already had the surgery. So that can sometimes be very reassuring to talk to someone that's gone through the surgery, who's done well, and they can give you all kinds of advice, even where to stay. That's a good restaurant, but very well too. It is so important to have the support, network with family and friends. Because, you're going to be out there for 2 or 3 months. Sometimes the spouse is working, they have to leave their job. So it's, some people, Dave's going to talk about his experience up there. And, having some other family members come for periods of time will be incredible. And so this is just an implantation of the battery. I'll just show you that. Dr. Squarey is going to talk about this. And this is the handheld programmer, and it's a patient's instructed to check the battery very frequently to make sure that it's working. And certainly they're being updated all the time, so we get better and better. These reviews. And so now we're doing deep brain stimulating training at the Miller Center, Dr. Squarey, patients with Dr. Squarey, Tammy McLean from Medtronic, attends that clinic, and she's just fabulous. She comes down and helps with the programming. She's there when the patients have to have battery changes. It seems like she just a drop of the hat, she'll fly here and make herself available for patients. And also see the physiotherapist and the nurse. And you see Jen and because our physiotherapist was fabulous and so important to our team. So the adjustments in the stimulator can be made at before patients were having to travel back and forth to Toronto or Halifax to have their stimulator adjusted. So this is making it, a huge difference for patients. And before, patients would have to fly to Toronto or Halifax to have their battery replaced, which is done in outpatients. It only takes 30 to 60 minutes to have that procedure complete, done. And most patients do not have to stay in the hospital at all. Some patients may have to stay in a night or two. But, when you think about it, 30-minute procedure, they would have to fly to Toronto to have that done. So, probably after some patients did talk in contact media, that was changed. So, it really goes to show how we can change things. So if anybody wants to be in the literature or information on deep brain surgery, you can start with this.
Thank you so much, Denise. Our next guest is Jennifer Shears. Jennifer is a clinical lead for us, psychotherapy at Miller Center. Now, I've never got to the Miller Center and seen anybody cranky for food. You go down there and they're always smiling, always. Jennifer and her amazing team are the ones that get us up and moving when we're down. Usually Jennifer is the loudest person in the room. But this week, she's had laryngitis, and she's been saving her voice for the whole week just for this. Now you're like it. Come, Jennifer.
Hello, everyone. So it's been a bit of a hard week for me. I love to talk. And who knows me, this is really hard. So I did have a little bit longer presentation planned, but I do kind of get in. It's my time so long. I'm not going to be as long, but it's really easy. So I'm beginning kind of here. So I was telling everybody this morning that Darth Vader has left the building. However, Danny Moore's walked in. I'm going to go with that today. So most of you know me. I think I've met at least 90% of people in the room at some point. And, how are you then? So anyways, I'm kind of a fixture at the Miller Center. I've been there for 18 years. Been a physiotherapist for almost 21. And absolutely love my job today as much as I did first day started. So I hope that I can show all you guys that today, how important it is to keep active. So I'm here to talk today about our role in attention and down the road when this wonderful procedure comes to the mind. So I'm not going to be happy. So I love this picture. So as you can see, we have dance. We already talked about the dance earlier. That's a big deal. So I'm talking about too. So physiotherapy is delivered as a part of a multidisciplinary approach, provides physical, psychosocial benefits for people with Parkinson's. It's an absolute fact. So people with Parkinson's again typically face a deterioration in mobility as time goes on. So other activities of daily living, and I will talk a little bit more about it. Does everybody know what activities of daily living is? So that's your washing, your dressing, your functioning in your daily life. So those things are absolutely effective in Parkinson's and with your caregiver support. So these are things we see regularly and try to facilitate and help with you. So it does result in lots of independence over time. Just like me, you're quick. So the role of your physio is to work with the interdisciplinary team. And we'll talk about our team information. I am very blessed to work with teams, Dr. Squarey, Dr. Privilege, and Dr. Elmer, Dr. Stefano. It's fantastic. We do a lot of really good work together. The only thing is I wish there was more health representation. Dr. Squarey talked about the occupational therapist, talked about the speech therapist. However, they're not on the floor there, but we generate the referrals as we see the need for that discipline being involved in your care. So we will get that going. So we're going to please again apologize and starting to get on. I like to consider physiotherapy exercise as the Parkinson's pill. So it's the non-pharmacological pill. So we are your exercise pill. So moving right on. So in terms of our role in the deep brain stimulation process, which is not here yet, and Mr. Reed can probably speak a little bit about his experience with involvement of the yes staff up in the trauma. I'd like to hear a little bit more. I see our role basically as a mobility assessment, pre-program and after. So I'd love to be part of that. We build with Dr. Squarey once that actually happens. So unfortunately, there's not more scientific evidence at this point regarding physiotherapy and deep brain stimulation. However, there's lots with exercise. So we're building on that today. So how can we go on with exercise and this? So we know how important exercise is with Parkinson's. So this is the adjunctive therapy. This is the new thing. How we can't go wrong, including more exercise. So, as physiotherapists, what we'll be assessing for you, so some of you are down, so many of you guys that have been to the dispersed bank or who have had physiotherapy assessment down outpatient, we assess your balance. We're getting you to stand on one leg, we're getting you to walk straight lines, tandem movements, settle you to the surface. We didn't tell you that, but this is what we're trying to do. So we're trying to assess your potential for fall, which we know is probably about 70% of you are going to have a fall. People with Parkinson's, at some point, falls are reality. And there's something we really want to make sure doesn't happen, because we don't want any fractures. How many times have I said that to you guys? No falls, no falls. First thing I ask, have you had any falls this year? So we're on you. So the next thing will be transfers. Transfers being bed mobility, so getting in and out of bed easily, getting up and off of a chair, off of the toilet. Those things are really, really important. So that's where most falls do occur, believe it or not, is in the transfer basket. And of course, the walking. Get every one of you to walk at some point in our assessment. And tell me, just bigger steps. Swing those arms. Does that ring true to anybody here? Big, big, big. So these are things that we will be assessing. Once we assess you, we identify where you have the biggest issues. And this is where we will give you the best information to make you safe and provide you with the best information on what exercise is most effective and safest for you. Okay, so let's start with some of the evidence. So with respect to exercise, there are areas that to strengthen the theory that physical activity and exercise is beneficial to people with Parkinson's. So first of course would be the effects on the nerve cells. If we start with animals for everything, okay? The rats, and they're working hard in these labs, really hard. So the effects on the nerve cells in animal models and Parkinson's disease. So we know from these models that there's improvement in the function of nerve cells and the potential increased survival of the nerve cells in the affected areas of the brain. You've all heard the word neuroplasticity. We're hearing this is a huge buzzword and it's beautiful. It's a beautiful thing and it's a reality. So exercise helps. So secondly, the exercise intervention studies with human subjects. So there's a lot of studies emerging here that suggest that exercise triggers several neuroplastic changes in Parkinson's brain. So as an example, it increases the excitability. So there's more chatter between the cells. So they're getting more effect. Also, human studies have shown people with Parkinson's who participate in exercise programs have a better quality of life. And I see that every single day of my working life. I see that once people are up and on the go, I see things happening in good ways for them from a mobility perspective. They improve walking ability, balance, strength, flexibility, and cardiovascular fitness versus those people that don't exercise. And I think it's across the board anyway, not only from a Parkinson's perspective, but more importantly for you guys. So also from example, dance, we talked about that earlier. So we all know how important dance is in music and how certain beats of music actually facilitate more movement. So that's something we're really hoping that you know, we can make bigger and broader. I think that as an adjunctive therapy, it's not only physiotherapists that do this. There's a huge number of people. And Derek can fit Parkinson's Society and helping with the grant money. Thank you very much, to try to make things more accessible to you in the community. So everyone's hearing about Pony Locale. So she's a dancer. Sarah Stoker is a dancer, and she's now doing a wonderful job with the Pony Pilates, working on her core. We can all work on our core. So which is the basis, it's our anchor. Everything has to work off our core. So when we tell you core exercises, sit at the edge of your chair in Parkinson's class, not sitting at the back of the chair and letting the chair hold you up. Perfect, I just saw what you did. I love that. That's wonderful, thank you. We're doing a good job, that's good. So it actually improves balance, which is critical for reducing falls. And the flexibility exercises, you know, all those hands up your hands, big circles, reaching exercises, rowing exercises. That's actually helping to improve your mobility and your coordination and reducing some of the stiff shoulders. Okay, I know it's hard to do sometimes, but it's really important. Okay. And I love her. I love her. I see me doing this. I see me doing it. So I found this comment online, and it's actually a neurosurgeon from UCLA, and he says you can exercise after deep brain surgery. The whole reason why we do the surgery is to improve your quality of life and get you to do things you want to do. I couldn't resist putting that up for you guys today. So he said, a doctor said it, not just a physio. So sometimes I gotta go there. Dr. Squarey is wonderful. Dr. Goodrich is good, but I think Dr. Squarey is a little bit more forceful with respect to the exercise piece, and I'm delighted. I love her. So again, our job is PTs, be cheerleaders for exercise. I was the lead cheerleader in Prince of Wales, so it's just carrying through in my professional life. People laugh at that, but it's an actual fact.
I was a volleyball player there. She was a
Oh,
cheerleader.
I was, yeah. Go.
I wasn't born.
People don't believe it, really. So anyways, for our cheerleaders, like I said, to exercise, I recommend the safest form of exercise. So that's where I think our role is the most important, because we see where you're having the most mobility challenge in your balance. We understand the disease process. We just want to work together with all the other adjunctive therapies and people that are involved in your mobility, just so that the things are the safest. I know you all want to just go mad and jump around and be as active as possible, but some of those things we can just bring down a little bit. It's not that you can't do it, it's just the way you do it. So also there's many safe and evidence-based types of exercise for people with Parkinson's. The dance again, I'm not saying the dance is cycling. The cycling is wonderful because it's a rhythmical activity. So this is really good for people with Parkinson's. Walking, it's free. And I hear every single Thursday, yeah, but the weather. Oh, but this, but that. Yes, but you can go to the mall, and you can go to the grocery store, and you can use the cart, because they always ask, can we give you a walker? Absolutely not. So how do you do when you're using the grocery cart? Oh my God, I walk way better. And then I go, so what's the difference? But it's a grocery cart versus a walker. And I totally understand, but there's the example. Treadmill training and strengthening, those are things. Okay, so I'm going to leave you with this beautiful picture. And I want you to remember, this is your exercise, this is your brain on exercise, not on drugs. Okay, so thank you.
Blackcurrant jelly beer.
What?
Blackcurrant jelly toddy.
Thank you, Jennifer. Could you imagine going to the physiotherapy and having a bad move? You haven't got a chance. Our next speaker is Mr. David Lee. He's at the other end of the spectrum. I keep looking at David's hip for stitches. We didn't show my picture of stitches, but I do a good job. Just kidding. David Lee. I won't get into details about him. He's going to cover it all himself, except to say he's been an active member of the society for 10 years. And he was a pirate at our Halloween party. David is going to talk us through about his experience with surgery last year. And I want to know, David, your piano playing. Is that implant going to help you with your piano playing? Come and show us. Mr. David Lee.
Major lecture. Thank you people for helping me with this. I got to say, Jen, my experience up in Toronto wasn't as good as the one down here with physiotherapy. They told me to go back to Newfoundland and see the physiotherapist down there. It wasn't included in my program up there. Just rush, and didn't think home. And I was rushing until to get home. I walk outside now. Jen used to get after me for walking in the treadmill. Get outside. Get outside. How about the weather? Never mind the weather. Get outside. As far as the piano playing is concerned, I couldn't play the piano when I went for surgery, and I can't play it now. So we have to get that into I'll give you the background first before I go into the experience with the DBS. I was working as the officer in charge of Brookfield Fire Station in September of 2006. While watching TV, my hand suddenly started to shake. Nobody else noticed it, and as soon as I moved, it stopped. I thought that somehow I'd given it a knock or something like that. As the days went by, the so-called shake became worse. Whenever I stopped using my hand and put on a desk or table, it would shake. I began having trouble writing and doing reports, and I had trouble with buttons on my shirt even. Taking all these symptoms with me, I visited my family doctor, and he sent me to an internist. Said I had the classic symptoms of Parkinson's disease. To make sure he sent me to see Dr. Goodrich. Dr. Goodrich made a diagnosis of Parkinson's disease. And this was in January 2007. Just 4 months since the appropriate fire station. During that time, my handwriting was illegible. I was having trouble putting on my firefighting gear, and the tremor, as I learned to call it, was becoming worse. I informed my supervisor with the best in the fire department. I went on sick leave. I could no longer carry out the duties of Parkinson. Being the officer in charge of an incident, whether it be a motor vehicle accident, hazardous material incident, fire incident, or any many emergencies that might present itself, I could not continue, and any decision made by me on the scene would be surely be questioned. I, who had a serious tremor, made worse by extended stress, couldn't speak to the media without showing symptoms, was finished as a firearm commander. The final diagnosis was idiopathic Parkinson's disease, which was, and these two words really hurt, chronic and progressive. And we were given the diagnosis in 2007, the next 8 years were a struggle, constant tremor, rigidity, difficulty handling cutlery. At times, my wife had to cut my deals for me because the Parkinson's wouldn't cooperate. The simple thing like turning over a bed became I had to time my medications, which was much difficult. They say I was taking at one time 16 liters of a day. No more just jumping in the car to go to the supermarket. Everything was geared to turning over meds. Just a minute means a different thing to a person who has good Parkinson's than to a person who has. That's my wife. Just a minute. I don't know. Times were enough tough and the future looked bleak. Then I got the call from Denise. If I was still interested, they could do the deep brain stimulation or DBS surgery on March 10, 2015. I was ecstatic. You can see me being ecstatic. different things being ecstatic, but the person has to practice is the practice, the person doesn't. Big difference. This is ecstatic for me.
Dave's ecstatic on the screen there now.
That's ecstatic. But there are a few hoops to jump through yet. Video interview with the neurologist at Toronto Western. The neuropsychiatric exams are done here in St. John's, and the MRI here in St. John's. All were well. I was informed that I had to repeat the neurophysiological exam, the MRI, and the interview with the psychiatrist in Toronto. I did it all again. The DBS team there wanted to confirm the test results of the St. John's team to ensure I was a good candidate for the surgery. Again, the goal. After more testing with medications, instead of being on your meds and non-meds, which you will see in the video, I was informed that I was a good candidate for deep brain surgery. Doctors told me that it would improve my symptoms by about 52%. As I said earlier, the temporary surgery took place on March 10th, and I was due at the hospital at 6 a.m. that morning. At 8 a.m., I had the head frame installed. This appliance was actually screwed into my head. My head in turn was bolted to the operating table to prevent any movement. From there, I went to surgery. But somewhere between 3 to 4 hours, and I was waiting to answer any questions to how to replace the electrodes. From there, it was on to recovery, and the surgery was a major success. I would venture to say that the surgical team exceeded their 52% goal. No tremor, except for a minor transient one, which I expected to go away. No more rigidity, no more shoving of feet, and I handled it back and forth with vesting. All that was left was at the battery packing plant, where the implant will pulse generator, which was on March 12th, 2 days after the stimulation surgery. 2 weeks after this, the machine was turned on and the program began. During all this, my wife was with me. I don't think I would have made it over. Every time my family visited in Toronto, my daughter Margaret, my son Paul, and his wife, my second daughter Amy, the baby. Even a retired firefighter of mine and his wife, his little parents. But all this is firm support. This is such a family. Some people, parents, makes you go emotional. I don't know if you should take that or not. Trip for 3 months. Some costs involved was the rent of the condo, food, transportation, mostly taxis, and airfare. Some financial assistance offered by the medical transportation assistance program, sponsored by the Commission government. I have a website where I can give, which I can give to anyone who's interested. This gives all the details about the program and what it is written covered. Only phone and I will make ourselves available for anyone interested in the surgery. Try to find a house where it's hot or cold beverage. I don't know if I'll say that. All in all, it was a trip worth taking. To rid myself of these awful symptoms. There's nothing short of miraculous. I can't say enough good things about the people at the movement disorder clinic at Toronto West. Professionalism and knowledge was something I will never forget. It was truly a humbling experience. See other people carry their Parkinson's burden. If you do a burden, you lift it.
I'm putting on the after one.
Oh, okay. Well, that's all I have to say. I reiterate, if they want to see me and talk to me about it later on, please feel welcome to come up here. Well, thank you very much for your attention.
While we're waiting for Dr. Squarey to come back for a minute, those people who are on webcast, turn you back towards the podium for a second, those who are still there. We understand there are some problems with the audio feed from the webcast, so we're trying to troubleshoot, and unfortunately we couldn't solve that problem. So what I'm going to do is either try to clean up the recorded version we have of this session, if we can, or we'll get all of our speakers to do this all over again without the audience, and we'll record it with good sound and post back up as everyone's got a good version of what happened here. Are we okay, Dr. Squarey?
Just working on it.
Okay. Okay, well, a couple other things. And while I'm here, Shears stops for one thing. Those of you who have been lucky enough not to vet me so far in your lives, I'm the executive director of the Parkinson Society in Newfoundland and Labrador. A couple of quick things. Our Christmas party is coming up on December the 9th. For those people who are interested in respond, contact us. And there is we also have some tool bulbs left for sale. In case anyone needs more tool bulbs, button up front. You buy 3 bags for a free t-shirt today. That's special. Let's see, what else I got going on? Question.
Choir will start on the 8th of January in Suncor Hall, 10:50 at 4 o'clock.
Okay, this is very exciting news. So this is a cross-generational choir that we're starting in the Parkinson Society along with students at the Faculty of School Music and other neurological conditions as well. So what are those dates again, Joe?
January 8th.
January 8th?
At 4 o'clock.
4 o'clock.
Suncor Energy Hall and room 1050.
Room 1050, yes, School Music.
Music.
Right. Okay, that's where you're good. All right, welcome back to the podium. Spirit.
Okay, so we couldn't get one of the videos up and running, but for anybody that wants to look at it, it was a documentary that was done by David Suzuki. It was looking at DBS. It was on Alzheimer's disease, but there's a clip there where Dr. Andres Lozano, who's a neurosurgeon who does functional neurosurgery in Toronto, described using deep brain stimulation for the treatment of Alzheimer's disease. So for anybody that wants to look at that, you just have to go to the CDC website and Google David Suzuki and Alzheimer's, and you'll be able to watch that. So I'm sorry for that, but we'll keep going. We can skip through that. So, as I mentioned, we do use deep brain stimulation for other things aside from Parkinson's disease. I mentioned a few already: tremor, dystonia. It can also be used in the treatment of epilepsy. And we're investigating deep brain stimulation for the treatment of other neurological diseases, other movement disorders like Huntington's, tics, Tourette neuroacanthocytosis, tardive dyskinesia, etc. I also was in Toronto recently and we talked a lot about use of EBS treatment of depression and anorexia. Okay. So before I finished, I think everybody's, myself, Dr. Goodridge, I'm sure the Parkinson Society has received a number of calls about, recently in the news, there's been a study that's, and it was presented at the neuroscience meeting, that a drug called I can't pronounce it. Not, what? No, not quite. If we go to the next slide. Nilotinib. There you go. Anyway, it's an FDA-approved drug for the treatment of leukemia, and what they've done is this researcher out of Georgetown University used it at a smaller dose of 150 to 300 milligrams at night, and he gave it to 12 patients. 11 finished the study, and 10 patients were shown to have improvement in their motor ability and cognitive function. And so these patients were diagnosed with Parkinson's disease or dementia with Lewy bodies. They also saw that there was a statistically significant change in toxic proteins that are linked to neurodegenerative diseases. So they measured these toxic proteins in the cerebral spinal fluid, which is a fluid that bathes the brain and the spinal cord, and they found that they were reduced. So it's thought that this drug actually turns on the garbage disposal machinery inside neurons and clears them of this toxic protein and prevents their accumulation, but you have to take it every day, so it clears it every day. It's important to recognize this was a very small study. You know, it was really 12 patients, only 11 of which completed the study. It was only 6 months, and it was designed as a safety trial to make sure that the drug was safe for the treatment of patients with Parkinson's and dementia with Lewy bodies. And so therefore, it's not, you know, a randomized placebo-controlled trial where they compare the drug to a control group. So, of course, there's further study underway, and those trials are scheduled to start in 2016. So just to summarize, deep brain stimulation, it increases your on time. You're on for probably more than 6 hours 6 hours more per day, and that's a lot for people that have Parkinson's disease. It's been shown that there are long-term improvements in your motor function, your quality of life. I think we've talked about that today. It simplifies your drug regimen. All of you, if you're on Parkinson's disease medications, can. I can't even remember to take my multivitamin in the morning, so I can't. My hat's off to you for remembering to take your pills all the time. We hope and we try to reduce your total dose of medications by about, on average, as I've said, 40 to 50%. It also has been shown to reduce the severity of those dyskinesias and the duration of them. And establish an effective treatment. It's an established and effective treatment for drug-resistant Parkinson's disease as well as other neurological conditions, and it's well tolerated with a favorable safety profile. So I think that's all I have to say. I want, on behalf of myself and Jen and Denise, we want to thank the Parkinson's Society for inviting us to speak to you today. Thank you to David for sharing his experience with us. I hope that we've taught you a little bit about, you know, some new innovative and cutting-edge technology for the treatment of Parkinson's disease. Thank you. I'll be happy to take any questions, and then I'm going to invite Denise and Jennifer to come up, and Jen, come up. Okay, well, you can try. We'll try and field any questions that you have related to deep brain stimulation. Yeah. I know. Now, how am I supposed to answer that question? So, in general, it's the age cutoff is about 65 years of age, although they have done it on people older than that. So it tends to be reserved for people that are less than 65 years of age, although of course, you know, there are exceptions to that. There's always hope.
Always, always, always hope. Anybody have any other questions? Well, I can tell you that I think I see all of the patients that have deep brain stimulators in the province, and we have about 25 to 30 patients now that have had these stimulators implanted. You know, it started with a small number, but certainly over time the number is increasing. So those patients would be patients that have a plaque that are causing them to have an uncontrollable tremor. So it helps with the tremor. Where? I couldn't answer that question. I don't know how many surgeries are completed per year in Toronto. So our goal after looking at the stats would be some, you know, we were thinking 1 per month, but, you know, after looking at some of the statistics, it might be more 18 per year. That go, yeah. We're trying. So we have approached, a good question, we have approached the powers that be at Eastern Health. They have looked at it and at the present time have thought that it's not financially feasible, but they are continuing to look at it, and we are continuing to advocate on behalf of the patients.
In County, we have a Parkinson Society in Labrador. It is way up there as early as
So if you were to refer to Toronto, there's on average probably 6-7 months waiting list just for that initial assessment. After you've been deemed a candidate, then you have to wait probably another 5-6 months before you're called back for the surgery. And so then you're up there for another 2 to 3 months after that. A year before you get your surgery done, yeah, for sure. So up until, you know, the past year or so, there were 2 neurosurgeons that performed the surgery in Nova Scotia. Both have since left, as Denise mentioned. Right now, I understand that Nova Scotia has an agreement with Montreal, Quebec, that their patients are going there. There are no, the surgery is not being performed in New Brunswick or PEI as well. Yeah, so there are no centers east of Montreal.
I'm just curious.
You're asking me if they're left with, no. You can often, there will often be a bump there where you can feel where the lead was placed. Well, come on down.
Do you think outside at all, or do you think it's in the brain itself?
You can.
So one time the surgery would be an allodotomy, where they would make it from patients before the brain stimulation was used. But now it's not a permanent hole made there anymore. Actually, if the electrodes were removed,
It's reversed.
It's reversible.
That's the nice thing about DBS therapy is that it can come out. It is reversible. They're very small. Yes. You were. Hi, Mona. Well, yes, ultimately, we'd like to do the whole kit and caboodle because, you know, realistically, it's really nice to see where these electrodes go for me in terms of programming after. And to be the first one that turns it on and to program it, that's really crucial in understanding what your stimulator does. But I mean, right now we do most of the preoperative screening here, and we certainly now are able to do the programming. The beginning of the programming, in general, to date, Toronto Western has requested that patients stay and have their initial programming done there. But I think that would certainly be an option. It would be my preference. Yeah, that's right. It takes 4 to 5 weeks before they turn it on, and that's because there's a lesioning effect when they drop the electrodes, and they have to wait for the healing to take place before they turn it on. Agreed. Agreed. Yep, certainly would be my preference.
I know that Parkinson's obviously but how do we know someone's a candidate for this? Usually, or does the doctor recommend, or you know, how would my father know whether he's a candidate unless he?
That's true, and that's really important because, you know, determining the success of deep brain stimulation, one of the important factors, or if not the most important factor, aside from where we put the lead, is choosing the right patient.
So is everybody in the room able to?
Everybody in the room is able to.
To see if they're okay?
And not a clinical trial. They're certainly allowed to come and see their neurologist and be assessed. Yes, yeah. So we're just trying to educate everybody about what that is, so you can talk to your neurologist or your treating physician about, am I a candidate for DBS? You know? Yes. I'm sorry. I know you've been having your hand up for a while. Okay. Yeah. Well, pardon me? New technology is a good one. Maybe it's not working for you. Maybe you develop an infection and it has to be removed. Well, right now, that would be the goal, wouldn't it? Is that people would be able to return to work. I don't know what the probability of that is. Off the top of my head, I don't know if anybody else knows, but you know, that's the goal, is to keep people in the workforce. And there is an early STIM study where we are doing the surgery earlier and earlier. So. And it should be in the water supply. I'm just kidding. I'm going to kill myself on that.
Can I move that?
I talk about falls. Any other questions? I don't have any new news on stem cell research. I know some people still think it's, you know, going to be the be all and end all, but I don't have any other additional information on that presently. He has. He initially had a lesioning procedure and then went on to have, actually he had a stem cell transplant. I don't know if he had a lesioning procedure. He had stem cell.
He had he wanted just his tremor treated many years ago as an actor. That was his most important symptom to him. So,
as it is to a lot of people with Parkinson's.
Yeah, and as an actor, that was what he did for. So he had that many years ago.
But he did have this, didn't he have stem cell transplant as well? I'm not sure, but he did have deep brain stimulation. Mm. Mm-hmm. Oh, I'm sorry, I haven't read either. So you're one book ahead of me. Any other questions? Anyway, thank you very much. Thank you, girls.
Well, my meds are wearing off early. I guess it might be a little bit of stress. I want to thank Medtronics for helping us with the cost of our production here. I want to thank you, Kyna, Denise, Jennifer, and David. And David, your musical career. At the Christmas party, Mrs. Claus has asked everybody to bring their best pots so we can beat to the tune. Remember that, David, December 9th. This meta lecture series and other activities are changing our attitude about Parkinson's. Hope is becoming real. A new wind is blowing. Why? Let me give you a story. Our Halloween party last month. He came to our Halloween party dressed as a clown. Parkinson's had chained him to his wheelchair, but his mind was free. During a lively song, he was passed the ugly stick, and his wife and grandchildren helped him beat a tune with it. A little later on, I was over beside him, and I noticed he's trying to get out of his wheelchair. He's trying to lift the foot pads. And I looked at his eye, and I could see what he was doing. He wanted to put his foot on the floor to beat to the tune. Physically, he only tapped once, but in his mind, he held the beat. Then the moment of moments, a waltz. His wife caressed him with one arm, and with the other she held his hand and they outstretched their arms. And they danced. Her hips moved, swayed ever so slightly. The front casters on his wheelchair just pivoted in their sockets. In their minds, they swept the dance floor. Their hearts were in a far, far away place. Courage amongst overwhelming odds. We as a society have to honor that courage. This is why we do what we do. Each of us are different. Beth said we're like snowflakes, every person with Parkinson's. We have to honor such people. And every individual is different. We need to help them. Now for the Christmas party on December 9th. Bring your best pot. Thank you everybody on the internet, and thank you everybody here. It's been a great time. Thank you.
As I said earlier, we will be championing this within the society. It's way up there in our priority goals. We may need your help in that as well, putting the pressure on the right people to make this happen. So look forward over the next little while of our plan of attack to get this surgery being done here in Newfoundland and Labrador. Thank you. Have a safe ride home. If you have any questions, concerns, please feel free to contact me at any time. If you're not a member or you're not on our mailing list or email list, there's a sign-up sheet outside. Please sign up so you can be kept the rest of everything that we are doing, because we are doing a lot these days. All right, thanks so much, guys. See you next year.